Hello, a warm good evening, good afternoon, and good morning to people who have joined us from across the globe. Welcome to the 12th session of this webinar series on advances in thalassemia diagnosis and management. Today, we are discussing contemporary management strategies in non-transfusion dependent thalassemia. For those of you who are joining us for the first time, this is a collaborative effort between Thalassemia International Federation, Thalassemics India, Postgraduate Institute of Child Health in Noida, ICO India, and the session is also from the PHO chapter of Indian Academy of Pediatrics. Today, we discuss a very important topic on non-transfusion dependent thalassemia. Children who are underdiagnosed compared to transfusion dependent thalassemia, under-recognized in terms of the complications and the morbidity of these children are often under-recognized, and they often do not come or are not cared for by the healthcare system the way transfusion-dependent thalassemia is cared for. So I would, for the introductory remarks, I would like to welcome Dr. Michael Angastinoitis, the medical advisor of Thalassemia International Federation.
Hello.
Just
Can you hear me?
Yes, sir, we can hear you, sir.
Good. Okay, on behalf of the Thalassemia International Federation, I would really, or I am honored, in fact, to introduce, first of all, a subject of great interest to all of us, because non-transfusion dependent thalassemia can be quite a challenge to the clinician, when to transfuse, when to give chelation, what chelation to give. It's an important subject. And in the development of guidelines, there have been three names that have helped us along over the years. It's Khaled Musallam, Ali Tahir, and Professor Nika Gabellini. So let me just say a few words about Khaled Musallam. I'm sure actually that Professor Nika is going to tell you all about his career, but I just want to tell you what I think, my own personal experience. I think that Professor Musallam is a great talent in introducing, analyzing, and presenting scientific data. I think he's really one of the best and greatest teachers in medical education, one of the best that I have ever met. I think I have to say again that the subject is of great interest. I wanted to explain to Khaled also that our center in Noida is really a TIF collaborating center, which makes it a beacon, shining light on thalassemia and thalassemia-related issues across India and the world. So, thank you very much. Over to you.
Thank you, sir. Now I'd like to introduce our speakers. So as usual, we generally have a mixture of speakers from international speakers and Indian speakers in this webinar. So from the Thalassemia International Federation, we are honored to have Professor Khaled Musallam. He's the director of Thalassemia and Sickle Cell Center at the Burjeel Cancer Institute and Burjeel Medical City in Abu Dhabi, UAE. And as Dr. Michael just mentioned, he's an internationally recognized hematologist. He is a leading expert in thalassemia, sickle cell, iron overload, and rare blood disorders. He has a medical degree from University of Beirut and PhD from Leiden Medical University in Netherlands. And he has been a principal investigator and steering committee member for various landmark global clinical trials in thalassemia management. And the three names that you mentioned, we have also learned hearing these three names in thalassemia: Professor Ali Tahir, Professor Nika Gabellini, and Professor Khaled Musallam. So really honored to have you with us today. And he has authored more than 200 peer-reviewed papers, and this has a great research experience as well. I'm sorry for the noise. Then we have from our Indian experts today, we are honored to have Dr. Pooja Diwan. Madam is professor in the Department of Pediatrics, University College of Medical Sciences, New Delhi. And she's the editor of Indian Pediatrics as well, the chief editor of Indian Pediatrics. And she's a recipient of various prestigious honors, including the FIAP, the MNAMS, and the Fellow of Royal College of Pediatrics and Child Health, and author of more than 150 publications, and including the co-chair of the Thalassemia Guidelines as well, which has just recently come out. We also are honored to have Dr. Prantha Chakrabarti, the renowned hematologist, a globally renowned hematologist. He is currently working as the Chief Medical Director of Suga Health Corporation in Chennai. He's a distinguished hematologist with expertise in clinical hematology, bone marrow transplant, thalassemia, hemoglobinopathies, and I think he's more known for his innovations and revolutionary ways that he has taken. So currently he is exploring ways of transforming healthcare, especially medical education in our country. And he has innovative work in non-invasive diagnostics, telemedicine, artificial intelligence, etc. So we really have a very distinguished panel of experts today. I'll stop sharing now, and I would request Professor Musallam to kindly take over. We usually have Mrs. Shobha Tuli, the board member of TIFF and the founding member of Thalassemics India, join us for the context setting for India. Today she had an emergency, so she couldn't join us, but probably during later in the meeting, she'll probably be able to. We will hear from her if she is able to join us. Over to you, Dr. Musalla.
Thank you, Dr. Nita and Dr. Michael, for the great introduction. And it's always a pleasure to be participating in such thing because I also learn a lot. Really looking forward to the panel discussion we're going to have after this presentation to learn more also about the current challenges and opportunities in India. So I'm going to be revisiting mostly recent data so that it sets the scene also for a discussion that will follow afterwards. Basically, in non-transfusion dependent thalassemia, we cannot claim that all we know about it is 10 years old. Thalassemia intermedia per se has been one of the recognized phenotypes of thalassemia for decades, but there's a large body of evidence in terms of understanding the disease and also designing interventions for the disease that accumulated in the last 10 years or so, and I'm going to be focusing on those. These are my disclosures. So just to maybe start with the terminology, because probably the term non-transfusion dependent thalassemia was introduced, if I'm not mistaken, in 2010 onwards. But just to give you a bit of a history on why we started using this term, you're probably more familiar with usually the triad of phenotypes when it comes to beta thalassemia, at least in terms of beta thalassemia major, intermediate, and minor, where we know that these are phenotype-driven nomenclatures that are based on patient's initial presentation, where the patients who present in, probably the first 2 years of life, if not earlier, with severe anemia that requires immediate start of regular transfusion program. These were our classic beta thal major. And then we have our beta thal trait or minor, the carriers, and everything in between we used to call beta thalassemia intermedia. And we know that there is a somehow evidence-driven genotype-phenotype relationship understanding in this disease, where it depends on the primary mutations that the patient inherits in a compound heterozygotes or homozygotes way, or any other modifiers as well that can alter the alpha globin gene expression, or the gamma globin gene expression could also modify the disease to end up with those different phenotypes. We have relied a lot on the genotypic understanding of the disease to label patients as having major and intermediate, but we're shying away a little bit from that. As much as we have like this evidence from this large study with the International Working Group on Thalassemia that clearly distinguish outcomes and mortality over time in patients with severe versus less severe genotypes. But now, every almost couple of years, we're understanding more and more molecular secondary modifiers of the genotype that could actually get a beta 0 patient, for example, to not be transfusion dependent, to be transfusion independent, or a beta plus patient to become severely transfusion dependent simply because of the presence of those additional genetic modifiers. So back in 2013 or so, what's the first time we documented this in the literature to try to move away from the major intermedia naming, although they still stand and they're still absolutely correct to use. But simply because we thought that when we're telling patients that they have thalassemia intermedia, we're not being truly honest because it somehow implies that the disease is benign when it comes to complications and manifestations compared to transfusion dependent patients at least. But that's not necessarily the case, as you will see in the course of this presentation. So we started using the terms non-transfusion and transfusion-dependent thalassemia to replace intermediate and major, simply because we understood that receiving transfusion or not receiving transfusion is the driver of the underlying pathophysiology. And the field split in somehow in those terms since that time. So now we have the Thalassemia International Federation guidelines. We're releasing ones for TDT and NTDT separately. All the clinical trials of novel therapies, you'd see that there are two phase 3 trials, one in TDT and NTDT separately. So the terminology picked up, although it requires a little bit of explanation most of the time. And this is because mainly we understand that these labels are not static, they're dynamic, so patients could move, especially from NTDT to TDT. At the end of the day, transfusion receipt could be a physician or a patient choice. But even if we look at this cohort, which we analyzed from Italy, following up patients over 10 years, and we wanted to see, at least in this subset of patients, how many actually transitioned from being NTDT and to becoming TDT, and around 14% of patients across a period of 4 years, 10 years, were transitioned to become a TDT, which is what we called phenoconversion. The main risk factors for that were, as you'd expect, a low hemoglobin level that probably the patient couldn't tolerate, maybe their lifestyle changed, or the presence of comorbidities that opted the physicians to start patients on transfusion therapy, and they stayed on it, so they became transfusion dependent. So all the story with NTDT in terms of putting it as a disease that is not as intermediate as we think started with simple clinical observations in the clinic, at least where I practice between Lebanon and Italy. We realized that these patients are coming to the clinic with a completely different complication profile than TDT patients. And the complications we were faced with were not simple complications. They severe, sometimes irreversible. We're talking about pulmonary hypertension, thrombosis, leg ulcers, extramedullary hematopoietic tumors. So we realized that there is something going on to have the patients present to the medical care, to internal medicine wards that frequently, especially as they start moving into adulthood. And we wanted to check if what we're seeing is actually seen by at least our neighbors in the countries around us. So we developed this optimal care study, which was a landmark study to characterize the prevalence of complications in NTDT in the region, collecting data on almost 584 patients. And the reality was the same. So if you look at the table on the left, we see that, patients 22% of patients had osteoporosis. 14% of patients had some sort of thrombotic event in their history. 11% had pulmonary hypertension. So we realize we cannot call this disease as mild or moderate or intermediate simply because of this morbidity load that they face as they move to adulthood. And if you look at the graph on the right, you see that it is in this group of 120 patients that never received any form of intervention at the time. You see that the prevalence of complications is higher in the older age groups, which means that whatever underlying pathophysiology at play, it's cumulative, and the more the patients experience this pathophysiology with time, the more the more likely they will develop these complications. And not only that, but these complications were in fact the main reasons for early mortality in these patients. So this is again from the International Working Group. We compared the survival to the general Italian population. It was significantly lower. And the number one killer, or the first two killers, were in fact cardiovascular disease. But mind you, it wasn't the typical iron-related cardiomyopathy, left-sided heart disease that you would see in a transfused patients. It was more on the pulmonary hypertension, right-sided heart disease, vascular events, and thromboembolic events. And the second cause was hepatic disease, fibrosis, cirrhosis, even hepatocellular carcinoma. So this is the conclusion of what we understood of what's going on, which I'll break down into one pathophysiology at a time. We know that these patients, the ineffective erythropoiesis is not controlled because they're not receiving transfusions. so between ineffective erythropoiesis and hemolysis of premature red cell death in the circulation, they lead to chronic anemia that's obvious. And that chronic anemia and hypoxia over time inevitably will lead to some sort of organ dysfunction. But we also know that there is a state of primary iron overload, which was the first unexpected finding that we had, that these patients are not receiving transfusion. So where is the iron coming from to reach that dangerous levels? And also a hypercoagulable state that I will shed more light on. Um, the first thing that I'm going temporally how evidence evolved. The first thing that caught our attention was iron overload, simply because the whole field was more concentrated on iron chelation therapy in TDT patients. So we were looking at our intermediate patients or NTDT patients, and we realized that they're reaching serum ferritin and liver iron concentration levels that are almost as close as the TDT patients. So the question was why? And colleagues across the world from different labs in Italy and the US especially, we're looking at what's going on, and it was very clear that what's happening is that ineffective erythropoiesis sends these erythroid signals through various factors. Many were suggested, but probably erythropoietin was the one that was most reproducible, that leads to hepcidin hormone dysregulation and decreased release from the liver, which leads to increase intestinal iron absorption and eventually accumulation of this iron in the liver and other body organs. So the body is fooling itself that it needs to produce more red cells because of this ineffective erythropoiesis, absorbing more iron, but then it cannot produce those red cells, so that iron gets distributed and stored in the body. And the second question we ask is this, okay, is this iron reaching a level that could cause a subsequent morbidity? And the answer was yes. So we've done almost 14 observational studies, and we were able to link iron to almost everything. Obviously, there's a lot of confounding usually in observational studies, but we did as much adjustment as we could. And it was clear that iron could lead to hepatic disease, could lead to hepatic cirrhosis, and even carcinoma in the absence of transfusion, in the absence of hepatitis C virus. It could lead to renal damage, maybe compounded by anemia as well, and endocrinopathy and vascular disease. The next question was, when should we intervene? We cannot rely on the same threshold that we look at in transfusion-dependent patient because it's a different mechanism of iron loading. And we were able to identify through various studies three key points. First, that the serum ferritin value for the same liver iron concentration for the same total body iron overload is lower in NTDT than TDT, simply because when the iron is coming from intestinal absorption, it's going directly to the hepatocytes compared to the reticuloendothelial system and the macrophages, which is where you measure serum ferritin usually. That's why the serum ferritin appeared to be lower despite high LIC. The second finding was, or the second and third finding were, that the threshold after which we started seeing complications in those patients was a serum ferritin of 800, for example, in NTDT compared to the 1,000 and 2,500 in TDT. And the liver iron concentration was a LIC of 5 compared to the 7 and 15 that we commonly use in TDT. So we have the tools now to understand who to treat, at what threshold to start, and how to interpret iron overload levels. And this was followed by a clinical trial, which was the first trial that specifically looked at iron chelation and TDT with the ferrosirox dispersible tablet at the time. And the trial was run over 2 years using lower doses of the ferrosirox simply because there is no ongoing iron intake as heavy as that you get from transfusion. And the trial was successful, met its endpoint, and led to actually a remarkable decrease in liver iron concentration at a pace faster than in TDT, again, simply because there is no ongoing transfusion burden. And this led to the approval of the ferrosirox in patients with NTDT who are 10 years or older, with those thresholds that were identified before, with a serum ferritin of 800 or more, or LIC of 5 or more. And that actually prompted us, because we had something new, we had something to offer, we had a new story to tell in NTDT and intervention. That prompted us to develop the first TIF guidelines for NTDT back in 2013. And the main focus there was the iron overload and iron chelation, with an algorithm that we still use in the updates of the guidelines until today. And when we look at more long-term data, this is again from the International Working Group on Thalassemia, it was very clear that those patients who started iron chelation therapy over time had less, for example, hepatic disease-related mortality. So even clinical hard points were being met. Now, in more recent years, as much as it's very obvious that these patients had anemia, but we started questioning, we call these patients NTDT, maybe because we thought they don't require transfusion, but it was more that we don't give them transfusion. We decided that this is a presentation with a 7 to 10 grams per deciliter. Patients could tolerate that. Why would you put them on a regular transfusion program? So we wanted to question that behavior, and we looked at data over 10 years and more. And it was very clear to us that those patients that had hemoglobin levels over time less than 10 grams per deciliter, they actually develop far more morbidity, those morbidities that I mentioned earlier, pulmonary hypertension, thrombosis, etc., much more than those who had a hemoglobin more than 10. And we also were able to see that variation by 1 gram per deciliter was able to reduce that risk by around 28%. So a hemoglobin of 8 has 28% more risk of developing morbidity than a hemoglobin of 9, for example. And you see that these values were taken forward to novel therapy development. When we looked at the combination of the iron overload and anemia, we saw a synergistic harmful effects. So if we look here at mortality, at the graph on the right, you see that patients who had hemoglobin less than 10 and serum ferritin more than 800 had far worse survival compared to those who had either alone or neither of these two risk factors. And this is a more recent study that we looked at the percentage of time patients were in favorable risk categories. So they were at a serum ferritin of less than 800 and a hemoglobin above 10. So the more percentage of lifetime these patients were in the safe zones, they had better survival and lower morbidity rate when we look at NTDT patients. The challenge here is that what do we do with the anemia? If we decided that we cannot leave it untreated, the hemoglobin less than 10 is a risk factor. It becomes even more imperative to treat if a patient already has symptoms. So the only thing that we have obviously is transfusion. And we do know from cohort studies that the NTDT patients who transition to become regularly transfused actually, of course, provided that the iron is controlled, did better in terms of survival and morbidity than patients who did not receive regular transfusion. But the challenge here was that we'd rather try to look for other tools to be able to raise the hemoglobin than switch all of our NTDT patients that have a hemoglobin less than 10 to become transfusion dependent. We already have challenges in blood supply and iron chelation adherence in NTDT patients. So it's going to be public health wise not that the best solution to recommend regular transfusion for everyone. And that's why two at least drugs were developed. There were others that reached phase 1 but did not show the same, let's say, clinical benefit that we saw in animal models. But the ones that made it into late development and got approved, the first one is luspatercept, which is it is a first-in-class erythroid maturation agent that works on the late stage of erythropoiesis compared to EPO, for example, that works on the early stage. The luspatercept was evaluated in NTDT in the Beyond trial, which was a phase 2 randomized double-blind placebo-controlled trial that looked at luspatercept, which is given every 21 days as a subcutaneous injection at a dose of 1 up to 1.25 milligram per kilogram. And patients had to have a hemoglobin less than 10 because of what I said earlier. And the primary endpoint was to improve the hemoglobin by 1 gram per deciliter at least, with a key secondary to look at a specific non-transfusion dependent thalassemia patient-reported outcome measure of tiredness and fatigue. And the trial met the primary endpoint. So there were 77% of patients that had a hemoglobin increase of 1 gram per deciliter or more compared to 0 on placebo. But the key secondary endpoint was better in luspatercept versus placebo, but it did not reach statistical significance. Despite that, the drug received EMA approval, but the submission with the FDA was withdrawn because there was lack of agreement on benefit and risk. And it was approved in EMEA in Europe and in many countries that follow Europe in 2023 for the management of adults with NTDT. And we have long-term data now that was also published later last year. That the benefit of the increase of 1 gram per deciliter of hemoglobin is sustained up to 240 weeks, at least was the last final follow-up in the extension of this trial. We also looked back to see how many of those patients that entered the trial with a hemoglobin less than 10 we moved them to that safer zone of more than 10, and you see a cumulative number of patients, up to 70% of patients were switched to have a hemoglobin more than 10 eventually at the end of the study. Despite the fact that the key secondary endpoint was not met in terms of significance, but when we specifically look at those hemoglobin responders, you see a clear correlation like the graph on the right in terms of the improvement in the anemia-related symptoms of tiredness and weakness. And we simply put that patient-reported outcome measure because regulators at the time needed something more than an increase of 1 gram of hemoglobin. We cannot show a decrease in morbidity risk in a 1 year trial that requires probably 5 years of follow-up. So we had to use a patient-reported outcome that was developed specifically um, for NTDT. But even now that we have a longer follow-up of and this was just published last month in the European Journal of Hematology, we looked at other PROs like the FACIT-F for fatigue in the trial, and we saw that the more patients had the hemoglobin improvement over time, we started seeing the improvement in symptom a little bit in a delayed fashion, almost after 48 weeks of the erythroid response. The safety of beyond in terms of luspatercept, the key adverse events are usually a headache, increase in blood pressure that requires some monitoring, and bone pain. But there were also some incidents of thrombotic events and increase or worsening of extramedullary hematopoiesis pseudotumors that were higher in luspatercept than placebo. And that's why there is some sort of caution. They're not contraindications for treatment now, but patients who already have risk for those should be probably deprioritized to receive luspatercept or require a careful monitoring when they're on it. And the latest version of the NTDT guidelines by TIF in 2023 already included all of this new anemia story. There's a table that says what we need to do about hemoglobin less than 10 with and without symptoms. And we have all the treatment options here, which could be still transfusion or obviously luspatercept. I know that in India there is a common use of hydroxyurea and thalidomide that we probably will talk about in the discussion. But in terms of evidence base, we still, at least at the level of the guidelines, because most of the data comes from single center experiences or small trials. We don't have that typical pharma development program with a phase 1, 2, 3 development for us to judge the data carefully to make wide recommendations. But we can discuss that more in the discussion session. And lastly, the other newer molecule or drug or agent that came into the picture as well is mitapivat, which is a pyruvate kinase activator. This initially started being developed in sickle cell disease, and it was already approved and developed for pyruvate kinase deficiency. In thalassemia mouse models, it was very clear that it's doing something, and we understand now why. The ineffective erythropoiesis consumes the energy supply of the red cell or the erythroid progenitor cells, which actually worsens the ineffective erythropoiesis itself. So with a PK activator that works on the glycolytic pathway, it increases ATP production and helps somehow in improving the survival of the red cells, whether in the bone marrow or the circulation. And the key clinical trial that was evaluating mitapivat in NTDT almost had a similar design to the Beyond. It was called Energize. Mitapivat is an oral treatment given twice per day. And again, the trial included patients more than 18 with a hemoglobin less than 10 for a primary endpoint of increasing hemoglobin by 1 gram. It was presented 2 years ago and was published in the Lancet last year, and the percentage of responders was slightly lower than Beyond. Around 42% patients responded versus 1% on placebo, but the mean change in hemoglobin in those responders was around 1.56. And the effect was seen across all subgroups. This trial, the difference also from luspatercept is it included both beta and alpha thalassemia intermedia, HBH disease. And the benefit was seen across both groups. And the key secondary endpoint was again here a patient-reported outcome, but it was the FACIT-F fatigue, which is a fatigue score mostly used in anemia studies in cancer, and it actually met the endpoint in this case with a significantly better improvement on mitapivat versus placebo, and we even saw some improvement in some more known or classical measures like the 6-minute walk tests. When it comes to mitapivat's safety, most of the adverse events were manageable, very few severe. Headache, mostly nausea, some bone pain. Also, some of our patients experienced that. And there were few, up to 5 cases of hepatic enzyme elevations, especially in the first part of the treatment. So that's why, again, the recommendation now is to do careful monitoring of liver enzymes in the first part of the therapy. And mitapivat is now in the period of its approvals. It received FDA, EMA, and some approvals in Gulf countries in the last few months as well. If we compare luspatercept and mitapivat, of course you can't because you don't have a head-to-head trial, but if you're interested, this is a publication we had last year to compare the data. More or less, we can say that both have an effect when it looks at hemoglobin improvement, but we still need to see real-world data from both drugs to see what would be the long-term impact on the morbidity risk in those patients. And lastly, just to leave you with this, we also published this interesting paper last year where we told the whole NTDT story in a visual infographic way. So we made it specifically if you want to use it to teach for or educate your residents and fellows, and it has an appendix, patient-friendly leaflet at the end that can be used. It should be free to download from American Journal of Hematology if you're interested. Thank you.
Thank you, Dr. Musallam, for that extremely concise discussion, a quick discussion rather on what are how the whole concept of NTDT evolved and how the treatment has changed over the years. I can't see any questions in the chat as of now, so I think we'll go to the questions that we have kept, and then at the end of it, if there are more questions from the audience, we can take it up.
Sure.
So I would request the other panelists also to join. And we have kept 3 cases today, and 3 rather very common cases that we encounter in practice. So over to the first case. So this is a child with, I would request the ECHO team to kindly mute. So this is a 13-year-old boy with beta thalassemia intermediate. He's non-transfusion dependent thalassemia diagnosed at 4 years of age. Initially, he required transfusion every 2 months as per the parent, but hemoglobin thresholds, we do not have at what hemoglobin he was being transfused. Over the last few years, he has remained largely transfusion independent. His hemoglobin in the last few records is around 7 to 8 gram per deciliter. He attends school. And I noticed that you mentioned fatigue and tiredness. So these are complaints which patients usually would have, and many times they don't tell us, and we don't unless we probe them. So in this case, there were no complaints as such. We can see that at 13 years of age, he is grossly his growth is affected. His both the height as well as weight is affected. He weighs just 24 kilos. He has splenomegaly, which is around 2 centimeters. His ferritin is very high, considering that he's never been transfused, and by the fact that you mentioned that ferritin was probably less of it's not a great marker in NTDT any which way. And he's not been started on any chelation as of now. He continues to be on hydroxyurea, so probably the same dose which has been there from the beginning, which is 1 capsule daily of hydroxyurea 500 milligrams, and he's on folic acid as well. So I'll start from Dr. Pooja, ma'am. Ma'am, would you, regarding hydroxyurea, I think this is something which we have discussed in the earlier webinars as well, that hydroxyurea continues to be prescribed very frequently to almost all patients with non-transfusion dependent thalassemia, and even for a few of the transfusion dependent patients as well. So in your practice, would you give a trial of hydroxyurea to all your patients? And is there any considerations among the different NTDTs between beta versus E beta? Would you have the same practice?
So thank you, Dr. Neeta, for inviting me here. And to be honest, hydroxyurea is something which we do use routinely in NTDT patients. So the first part of your question would be a yes. Although I do feel that it should be individualized as far as possible. But in NTDT, there are certain modifiers, genetic modifiers, which do predict the response to hydroxyurea. More often than not, most centers will not have the entire genetic profile of the patient. So we do know that XMN1 polymorphism, your BCL11A, KLF1 mutations, presence of delta beta thalassemia, coexistence of hereditary persistence of it. These are all predictors which predict a favorable response to hydroxyurea. But what in practice we do is we give a trial of hydroxyurea and we assess the rise in hemoglobin. So if we find that after 6 months of therapy with 5 to 10 mg per kg of hydroxyurea, we find a hemoglobin that has risen by 1, is decreasing the transfusion requirement, then we do tend to give hydroxyurea. Moreover, we know that growing age, especially for pediatrics age group, I can say that you want their growth and their attainment of puberty should not suffer. So you're looking at ways to improve the hemoglobin to more than 7 to keep them growing well. So trial of hydroxyurea will not be bad. At the same time, there are certain conditions where you should definitely give hydroxyurea. So if your patient has a history of thrombosis in the family or has been splenectomized, or there are other morbidities, as Dr. Musallam just highlighted, maybe pulmonary artery, these would be artery hypertension. These would obviously be in the older patients. So these patients would benefit from hydroxyurea and it should be given to these patients.
Okay, thank you. So once we start hydroxyurea, Dr. Pranjit, so you continue to see patients into adulthood. So now a lot of children transition into adulthood now. So how long would you consider continuing hydroxyurea? One, if you do not see a clinical response, that's point one. And point two, if you have a clinical response as well, do you continue it into adulthood completely, or do you stop after like 18 years growth and puberty is attained?
Yeah, thanks for those questions. And what I would like to say is, whenever I start hydroxyurea, as Professor Diwan pointed out, it's more like a therapeutic trial. And I define my goalposts at the beginning. What am I expecting, right? So is it an improvement in hemoglobin, improvement in the growth velocity or energy level, or decrease in spleen size, or, transfusion avoidance, or reduction of ineffective erythropoiesis, where I do not have many tools to assess it. So you have talked of two situations. If it is working and if I'm happy with monitoring, I usually ask myself, is it helping the patient's growth, anemia, spleen, or quality of life? Now, in my cohort of patients, usually I continue it beyond 18 years of age. But sometimes, though fortunately it is rare, we have had certain patients who had developed certain ulcerations where only stopping the drug, and this we have seen in myeloproliferative neoplasms also, that stopping it actually leads to recovery from those. I tend to control it until and unless there is some event of cytopenia or some intolerance. Now, if it doesn't work, if there is no improvement in whatever I wanted as an endpoint, then I do not continue it for more than 6 months. And this is what I explained to the parents also, that I'm trying this, I will see it, and because we cannot reach the so-called maximum tolerated dose, which is recommended, we actually published a randomized control trial from our institute, and we saw that 10 milligram per kg was what we were using most. So if that doesn't work, we do not try to increase it to a higher level. We say it is not working and we stop it.
Thank you. So if it's not working, as in 3 to 6 months, you'll stop it. And if it works in terms of hemoglobin growth, spleen, as well as quality of life, these are your 4 outcomes that you're looking at, and you will continue it into adulthood. Okay.
Right.
So that brings to the next part of the question to Dr. Musallam. So in a child with the hemoglobin, our patient of ours is keeping a stable hemoglobin between 7 to 8 at 20 milligram per kilogram of hydroxyurea. with not many complaints. So in our country, hydroxyurea parents generally don't have many complaints at all. So they are very happy with this hemoglobin. Although it's the doctors who are like aghast at his growth and his a delay in puberty and so on. So what would be your advice in this scenario? Would you go up on the dose and see? Would you change to another agent like you mentioned, luspatercept? Would you ask for transfusion regimen, or would you look for some other, like his ferritin's very high? Would you want to what all would you do in your practice?
Definitely. So you have to do something because the hemoglobin is low, is less than 10, and poor growth is going to be, if you don't manage it now, you're going to lose your opportunity to deal with it. The ideal scenario for this child would be a regular transfusion program that doesn't necessarily need to become a permanent one, but at least in the period of growth to keep the patient on a transfusion program would be ideal. But to your point, it's all a matter of how effective can you manage the iron chelation, how adherent can you be, what's experience with the iron chelation regimen before you start with this. Now, I don't know if increase in dose of hydroxyurea will do much. Adding another agent could work, but these are all, I mean, it's a trial and error, so it's experimental. As long as you keep to Dr. Prantar's point, you keep your window of checking if it works small because you don't want to lose time with this child. So you don't want to try it something for a year and then decide it's not working. If you see most of these erythroid stimulants, let's call them this way, should have an effect in the first 3 months. If they don't, they're not gonna. Okay, maybe 5% can be late responders. So if you mix hydroxyurea here with EPO or with thalidomide or short-chain fatty acids, you can see tons of case reports in the literature, but nothing is solid science in terms of a combination therapy. If transfusion receipt is feasible, is practical, is applicable, and iron chelation can be maintained, it remains the best choice for this child. If that is not the case, then a trial of combination of hydroxyurea with some of the other agents that are being repurposed now could be, but again, not to wait for more than 3 to maximum 6 months to see a response.
Thank you. Yeah, so you suggested in transfusion regimen, and that's often the toughest thing to convince a NTDT family to go on
Yes,
a
yes.
transfusion
But when
regimen.
you tell them that it is for this period that you don't want to lose because these patients, if you don't treat them in that period, they're stuck with their short status, they're stuck with their delayed sexual development, they're stuck with everything, and that's it, you lose the opportunity later. So maybe when you put the weight, and that doesn't mean that they need to be for life. We have so many patients with NTDT that were regularly transfused during the growth spurts, etc. And then they were weaned off of them. And then maybe, yes, hydroxyurea was enough because they were able to function with a hemoglobin of 8, 9 well, and we passed this critical growth period. So maybe if you discuss with the patients that this doesn't mean that it's lifelong, like in TDT, they could absorb it a bit more.
Yeah, thank you. So now, if we have decided to shift to a transfusion regimen, so many times we do it and we put them on a regular transfusion now. So what happens to the hydroxyurea, Dr. Pooja? Would you continue that for that added little benefit that it may offer, or in a regularly transfused patient, does hydroxyurea really work? You're muted, ma'am.
In this particular case, since the transfusions are being planned for maybe 1 or 2 years or 3 years, I would probably continue with a low dose hydroxyurea. And because ultimately the goal would be to stop the transfusions once I'm able to maintain the hemoglobin around 9 or 10 and the child has attained the growth or puberty that we wanted to. But suppose my reason for switching to regular transfusions is a non-response, and obviously the hydroxyurea has to be stopped. So, and there is no, as such, I would say that it's not a yes and no, it's a gradual transition. So there would definitely be a period of overlap when you are judging how frequently you need the transfusions. And a patient who's regularly transfused, because the mechanism is going to be different, the transfusions are actually going to suppress the drive, the erythropoietic drive. And by giving hydroxyurea, we are stimulating the HbF production. So both have a counter effect. So I don't think if a patient is regularly transfused, he would need hydroxyurea to be continued.
Yeah. But often we see that that gets continued. So that's something I think for the trainees in the group and there are some few patients also, I believe. So that's something if you're transitioning to a TDT, you may not require even if it's for a short duration of time, you may not need to continue hydroxyurea. So Dr. Musallam, you beautifully showed how ferritin is different in
Yeah.
TDT and NTDT. Could you just repeat it? I think
I'll
that was for
re-summarize
the
it in a
people in
practical
the
way.
group. Yeah.
Exactly. So,
Yeah.
the first thing to always be aware of is what I mentioned is that serum ferritin is we say inappropriately lower in NTDT compared to TDT. So sometimes it is on the lower side. If 1,000 is your red flag and you see it in 700, you'll say, oh, that's okay. But actually, if you go do a liver iron concentration by MRI, you see that LIC is actually 7 or 8. So if you have the luxury of having an MRI, that's always your sounding board in terms of understanding the initial status of the patient. So at least to do it in the beginning to understand where is the patient starting from LIC wise, and then you can rely on serum ferritin moving forward. But if that's not the case, then again, we're looking at an 800 as the flag of needing treatment. 300 is your target. So you can go down to 300 and chelation is still safe up to that level. And then you can give the patient a drug holiday because the iron loading in NTDT without transfusion is very slow. So they will need probably 3 years to go back up to serum ferritin of 800. So at least they can, get rid of the chelator for a while. Now, patients that present in this gray zone, we call it from 300 to 800, and you don't have access to MRI to verify if they're actually in the danger zone or not, you would need to rely on some other metrics. So obviously, you need to ensure that the liver function, endocrine function, heart function, everything is fine. And if you see any deviation from the norm, then you can consider that these patients require chelation, even if the serum ferritin is 700. We've developed a calibration curve to what's the probability of having a high LIC between 300 and 800, but this could be simply a physician's choice.
Yeah, thank you. So this patient somehow had a very high ferritin value, I would say, but generally patients that we treat with NTDT, they just come in with a ferritin level of, like you said, 700, 800 or
Yeah.
so, and we are to start chelation early. Dr. Pranthe, this boy is very short and he's not growing well at all. So what would be the multiple causes in an NTDT scenario compared to TDT? He's never been on chelation, so that reason is out. And how would you evaluate that?
Yeah, so I would evaluate it at 5 different aspects. One would obviously be, I would look at the mid-parental height. I would like to look at the growth velocity over the last 6 to 12 months, do a Tanner staging. But most importantly are the disease burden and the iron burden. So, when you see the patient, sometimes you don't even have the records of what was there. But I also try to look at whether there is any evidence of extramedullary hematopoiesis, because that gives me an idea as to how much the disease and the chronic anemia is contributing to this. In this child, I think that, as Professor Musallam has explained, iron burden itself can play a role here. And that's why an endocrine screen is so important. And, I would like to get my endocrinology colleague also to have a look at it and at least look at the basic cortisol, calcium, phosphate, vitamin levels, and not to neglect the diet, the nutrition, some chronic infection. But mainly, I would look at the disease burden and the iron burden.
Thank you. Yeah, and in diet, definitely calcium, vitamin D3 as well, which we are to be supplementing all our patients. So, Dr. Pooja, in a very short or concise way, what all endocrinopathy should we be monitoring for? These children should be monitored for.
The endocrine complications are more or less the same that we see in TDT. Some of these are more severe, like osteoporosis is more severe. And even growth disturbances and pubertal changes are more common in these children. So starting from the age of 10 years, we would recommend these children to be regularly evaluated for hypothyroidism, hypoparathyroidism, diabetes, poor bone health, and hypogonadism. So these are the common endocrine problems that we would encounter. And of course, cortisol.
And the monitoring schedule, would it be similar to a TDT patient, or would it be more, it will be less frequent?
So it could be every 1 or 2 years, depending on your clinical evaluation of the patient. So the monitoring will be less frequent, and the age of starting, like we generally look for hypothyroidism earlier in TDT patients. But here, by the age of 10, these complications are, so with increasing age, these complications are more common compared to TDT kids, where you could have this even in younger patients.
Okay, thank you. And Dr. Pranthar, if you can give us a plan for this boy, this 13-year-old boy, what all should we be focusing for the next few years?
Yeah, so I would definitely sit with the parents and try to make them visualize, because I would tell them that the next 5 years would be the most crucial part of his life. And the aim is not transfusion independence, the aim is complication independence. So, as was already explained well by my colleagues, I would go in for a planned transfusion regime, saying that, okay, it might be a temporary measure, but I would like to get him the growth spurt which he deserves. And I'll also go in for chelation. And then if I do not get access to MRI, at least, as was mentioned, ferritin less than 300. And the periodic monitoring here would be every 3 months for me, with height velocity pivotal staging, and obviously along with the spleen size and other things. We have to explain, as you rightly said. They would say, there are other children who do not need transfusion, and they would actually, there are alternative medicine and other things they would like to go. So I think we should make it very clear that this is the plan to not only help the child survive, but to have a good quality of life and to prevent most of the complications through adulthood. So I think it is more about convincing them and then evaluating the plan, and that plan would include whatever we have discussed till now.
Yeah, thank you. And this is, like you said, this is the investment period for a good
Yeah.
adulthood. So if this is probably the last window of opportunity also for us. Okay,
Absolutely.
thank you. And we go to the next patient. He's a 15-year-old boy now. He has E beta thalassemia, and he's remained again. So it's not many a times, like I mentioned in the beginning, they're not under any healthcare service. So because of that, most of the decisions are made on their own or by physicians who near them, who kind of tell them that this is a milder condition, you don't need to go to the hospital as long as his hemoglobin is okay, and that's often the only cutoff that is taken to decide whether they need to revisit a hospital. So his hemoglobin has been around 8 and he's never been transfused. And he has a sibling brother who is again 12 years of age, who has a higher hemoglobin cutoff of 9.5. He also has NTDT classical facies, both of them. So this is a girl and this is a boy. Now, over the last 1 year, she has developed abdominal fullness, spleen size, which is now around 10 centimeters along the axis. And now we can see that there are cytopenias that are also setting in. Ferritin is 1,200 nanograms. So now again, growth, you can see there was one visit in an earlier center around at 6 years of age. You can see that even their growth was reasonably okay at that time. But in this second phase, when the growth should have actually, that growth improvement should have happened, she has actually faltered. Her growth has fallen. The both centiles for height and weight have fallen. So now I'll start with Dr. Musalla. We see a lot of families having more than one child with the same condition. So despite having the same mutation, they behave a little differently. Sometimes we have transfusion dependent and non-transfusion dependent in the same family. So what are the are the reasons for these different clinical phenotypes?
So we usually always say that the modifiers of disease, especially as phenotype-wise, can be primary, secondary, or tertiary. Primary is the mutation itself. And for that, yes, you should expect that specific mutation of IVS 110 or something and to give you the same hemoglobin product amount. But what usually is the case, and in many cases, due to lack of appropriate or available, further genetic analysis, DNA analysis, we're not aware of what's going on around the beta or alpha globin genes in more specificity. So the secondary modifiers are the first reason why things could be different for two patients with the exact same beta mutations or genotypes. The most common one that we're all aware of is the alpha deletion. So for patients who carry some alpha deletions, and these could come in magnitude, they will have a better, because it's all about the alpha to beta globin chain ratio. So if you have deficiency in beta, but you also have deficiency in alpha, then that imbalance is actually, although at lower amount, is achieved back again. So you have less hemolysis, less red cell premature death. There are also many new mutations that are being identified that work around alpha heat shock proteins, things that stabilize the alpha aggregates in those red cells that are having beta globin chain deficiencies. And obviously the HbF persistent fetal hemoglobin production, which we used to link to a few mutations, the delta beta thalassemia and so on. But now we have all these more variants like around BCL11, MYB, and many others are emerging that probably are not being screened for in a typical genotype analysis of a patient that could actually retain the ability to produce HbF beyond fetal life, and that obviously can improve the clinical phenotype. The tertiary modifiers, so the primary are the beta mutations, the secondary are the more, let's say, alpha and gamma, and their impact directly on the alpha to beta globin chain imbalance. The third could be genetic mutations or environmental factors that have implications on specific aspects of the phenotype. So mutations in the pathway to gallstones, in the pathway to osteoporosis or bone disease. So there could be some variants at the genetic level that could explain the different phenotypes or environmental factors. So there are a lot of studies that I'm not fully aware of on the impact of malaria and the phenotype of thalassemia, especially in Southeast Asia, and hemoglobin E, beta thal, adaptation to anemia. So there could be environmental factor that could cause that. So this is, it's a typical thinking like you'd have in any rare or genetic disease with variation in outcomes for the same primary mutation.
Yeah, thank you very much. So, so are these mutations similar for E beta, or are there any other mutations that define their variability, Dr. Pooja?
So E-beta essentially, there are studies from India where they have shown that basically the HbF production, whichever mutations are fostering that, are benefiting in offering a less severe phenotype. So your XMN1 polymorphism works there, in addition to KLF1 mutation and the others that we just talked about. In addition, there are certain clinical predictors also which have shown to offer a milder phenotype, like if the age at first transfusion is late, if the pre-transfusion levels are good, then such patients generally have a milder phenotype.
Yeah, so the one what he discussed as Maydol scoring, which would define as to what kind of clinical severity the patient
So
would
the
have.
presence of splenomegaly is also there, and how frequently the child is transfused.
Yeah. Dr. Pranthar, I hope you can hear us. So how would you define hypersplenism in this patients, and what would you advise for hypersplenism when a patient comes in with cytopenias?
Right. So, we were always taught that hypersplenism is a retrospective diagnosis, right? So, in certain conditions, when you remove the spleen, it proves that there was hypersplenism. But I think in this patient, I would define it both clinically and hematologically because other than the spleen size being mentioned as 10 centimeter, hemoglobin has fallen from 8 to 6.5. Platelets are 90,000. Total leukocyte count is 3,500 and neutrophils are only 30%. So, splenomegaly with multilineage cytopenia, that is functionally hypersplenism. But before labeling it purely as hypersplenism, I always like to exclude other reversible causes like infection, autoimmune cytopenia, marrow suppression, drug exposure, because sometimes what we see in this kind of patients is that there is hypersplenism due to worsening ineffective erythropoiesis, and a transfusion regime also reverses the condition to some extent. So I think that, yes, if I look at it, it is hypersplenism, but I think that the management also has not been adequate. So it would be a individualized decision.
Thank you. Thank you, sir. Now, how does splenectomy? So NTDT per se has a prothrombotic risk. What are the odds of increasing that risk if you'd get a splenectomy done, Dr. Masal?
Yeah, so we had that analysis in the optimal care study that I mentioned, which was mostly cross-sectional. And we also have data from a very large survey of that physicians filled around 8,000 on 8,000 patients. So the association is very clear. Now, in terms of magnitude, we're talking about around a six-fold increase in risk between splenectomized and non-splenectomized patients. And we believe that is the case because the hypercoagulability in NTDT is mostly driven by the hemolyzed red cells, microparticles, exposure of phosphatidylserine on their surface, activated platelets. So as you'd expect, the spleen has a very major role in scavenging all of those. So once it's out, they're circulating more freely and they can cause this hypercoagulability. But one thing to note that we're not looking here at an immediate, because there is a split of portal vein thrombosis immediately after splenectomy, more like a surgical risk. We're talking here about a risk that could be the median time, I think in our study was around 8 years. So since from between splenectomy to the emergence of thrombosis. So this is a long-term risk rather than an acute risk directly only after the splenectomy, because the disease is active all the time and the spleen is not there to do that job of scavenging those microparticles. So the risk is always there.
18 years from splenectomy to
8
first
years,
from
8 years. Yeah.
8 years. Okay.
Yeah.
Thank you. That's very nice. That's very good data to explain to the patients also.
Yeah.
So what are the absolutely, nowadays we do not advise at all. So in today's age with current treatment practices, what would be an indication to do splenectomy in this cohort of patients, Dr. Pooja?
The last splenectomy which I got done at my center was nearly 10 years back. But that's also because the number of NTDT patients that we see in our clinics are much lesser compared to TDT patients. And as far as possible, we do avoid splenectomy more so in younger children where the risks of complications are much higher, life-threatening sepsis, pneumococcal infections. So the only indications where I would promote a splenectomy would be a very symptomatic pancytopenia. So if the anemia is very low, and as in this case, he's already been on hydroxyurea but does not seem to be responding, and maybe a luspatercept trial could be given, and still if that doesn't work, the child has a bleeding manifestation or severe infections because of leukopenia, we would go in for a splenectomy. We've also done splenectomy where the patients have been very symptomatic because of a very large spleen. So they find it difficult to sleep. They cannot move around. There's a fullness in abdomen, a dragging sensation. So these are the other indications where I would recommend. And sometimes, as in this case, where hydroxyurea is not working or is contraindicated, in those cases as well, splenectomy can be considered after weighing the benefits and the risks associated.
And what are
these are more or less the same as the TIF guidelines recommendations as well.
Yeah. What are the vaccines and prophylactic measures? Just quickly, if you can discuss.
The vaccines would be we would recommend against the capsulated organisms, so Hib vaccine, a pneumococcal vaccine, both the polysaccharide and the conjugate vaccine combination. So we would first give a conjugate vaccine, follow it up with a polysaccharide vaccine, ideally 4 to 6 weeks before the splenectomy or at least 2 weeks before the splenectomy. If that's still not possible, then post-splenectomy vaccination. these would also require boosters, and we would also need influenza vaccines for these children to be given every year. In addition, chemoprophylaxis for prevention of infections like penicillin would be needed. So 125 and 250 milligram, depending on the ages, less than 3 or more than 3. The prophylaxis that you need to consider is, in addition, you would also be looking at, since we just, Dr. Musallam also mentioned, the thrombosis risk increases. So perioperatively, the patient may require thromboprophylaxis. And sometimes he may need lifelong aspirin therapy or anticoagulant therapy. The risk of thrombosis is very high, or as a secondary prevention. Moreover, when we are planning a splenectomy, ideally, I would also go in for checking for certain other things like an ultrasound, because sometimes we do go for a cholecystectomy simultaneously if the patient also has gallstones.
Yeah, thank you. Nowadays, it's becoming very, very rare. So we often, and I think hip vaccine is no longer available as a single vaccine, right? You have to give it along with the other vaccinations, the pentavalent vaccines, if I'm
Yeah,
not wrong. So
so
that also
yeah.
becomes difficult to give in our country. Yeah.
So we give the pentavalent, considering that whatever benefit it has to give.
Yeah. Dr. Musallam, so what would be our so first question is in this scenario, what would be your choice? Would you again growth is faltering? So would you, similar question to ask the previous case, would you want to add a new agent versus hydroxyurea and so on? And in a NTDT patient, Dr. Pranthar discussed hemoglobin, growth, spleen, and quality of life. Are these your targets as well for outcome, defining a good outcome in NTDT patients? Or are there any biomarkers which we can chase?
No, the biomarker has always been our struggle because even for the novel therapy trials, we're not able to look at anything beyond hemoglobin. I mean, hemoglobin is the ideal marker of ineffective erythropoiesis and what's going on. But the problem is, as much as we look at anemia as a condition, when it comes to regulatory agencies, most of the time they need something else. Although with iron overload, it's always fine to convince that the benefit is reduction in liver iron concentration. But when it comes to anemia, improving hemoglobin alone is not sufficient. So we have to look at other markers. I'm talking from a clinical trials perspective. Now, from a clinical perspective, of course, we need to look at what is the clinical value of improving the hemoglobin and if we're achieving the targets. So in an NTDT case, in adults, we're treating a pulmonary hypertension, so we need to see how the metrics worked. If we're improving cardiac output, we need to look at how metrics worked. But in the pediatric patients are simply they're mostly the growth parameters that we focus on more, and obviously patient-reported outcomes, quality of life, whatever is most relevant to the patient. Luspatercept in this setting for that question. Obviously, luspatercept is still not approved in children. There is a trial that is ongoing in phase 2 trial. Hopefully by next year we'll have the data. The mitapivat is the same, so it's only approved in adult, and the pediatric program is just starting. So unfortunately, we don't have, and that's the main challenge, that we don't have these agents that could actually do a better job in children than in adults, because you prevent the complications before they even happen. But as you know, the development program is sequential. So after the adults, now we're starting with the pediatric programs. And we'll see if the children would respond better. Again, as I said, the biomarkers are not, I mean, more for a scientific understanding of mechanism of action of whatever it is that you're doing. We look at nucleated red blood cells, transferrin receptor, and some, erythroferon, hepcidin, some of the more newer markers we're interested in. But to be honest, none of them usually told us the story beyond saying that, yes, things are going in the direction you want, but none of them made it to the clinical practice setting to say that this is a hard marker that actually, if you improve, like you have for, HBS in sickle cell or something like that. We don't have something like that in thalassemia yet, markers-wise. It's still anemia and ferritin.
Yeah, true. And even the other ones like facial features and all of that also is so subjective. So it
Exactly.
never gets to an outcome
Exactly.
assessment. Okay, thank you. And Dr. Pranthar, in adolescence, we often see that everything, children who have been stable earlier suddenly have a dip in hemoglobin during that period. So, what is the reason that we see that? And even in TDT, also, sometimes we have to increase the transfusion frequency at that point of time. So, what are the reasons that cause this?
Yeah, I think it is multifactorial. Obviously, number one would be the growth spurt itself. So it's the stress test for especially our NTDT patients because oxygen demand increases, the blood volume expands, and the marrow has to meet a higher physiologic requirement. Puberty and endocrine problems actually contribute to it because with the same hemoglobin level also, with hypothyroidism, some develop diabetes, vitamin D deficiency contributes. That same hemoglobin can be perceived as more of fatigue and, more of anemia. Iron overload we have already discussed, and I think spleen biology also, because the spleen also goes on increasing, and during adolescence it can sequester red cells and the other cells as we were discussing. And there are certain intercurrent triggers, like in sickle, here also, infection, some inflammation, and then the challenges we face in females who start menstruating. And I never ignore nutritional deficiency. So I think it is a mixture of everything, and I try to explain that this is the stress period, and as you rightly mentioned, this is also your time for investment for keeping the adult free of complications as far as possible.
So I think patients would, at least by 6 to 8 years of age, there should be one kind of proper assessment so that we decide
Yes,
how to do the next period once before they hit
absolutely.
puberty so that we
Yeah,
can
yeah,
manage them better. And
absolutely.
finally, our last case, and it's a young adult. It's a lady again, and she's never presented to a thalassemia center. She, in fact, she lives quite near our hospital only, but she's never visited as a patient till the time she is initial diagnosis from a pediatrician, then on and off CBC since then, and probably her hemoglobin is the target, that's the outcome that they were chasing, and that has remained well. So during COVID-19, she had probably fever, and then somebody asked her to get D dimer, and this D dimer came so extremely high. So that's when they visited a healthcare facility for the first time. And at that time, she was noted to have this NTDT with a splenomegaly and a hemoglobin of around 8 or 9, no thrombosis. And so she was just advised regular follow ups at that point of time. But as predicted, again, no real follow-up. Now, progressively, around 5 years later, now she's 22, she's presented with fatigue. She is mild hepatomegaly, splenomegaly is the same, no hypersplenism. Hemoglobin is 7 now. And she, on a with for this fatigue, was evaluated and found to have pulmonary hypertension with tricuspid regurgitation. Ferritin is 800. MRI was done, which shows the moderate liver iron overload, and she's not yet on any drug, for example, for that matter, not even on folic acid. So I would start with you, Dr. Musallam. NTDT patients, just if you can quickly tell the group as to how frequently they should be visiting the hospital, clinics and labs at clinically what all we should assess and labs at each visit.
Sure. So it's more or less individualized, I would say. We cannot say that all patients need to follow up in the same frequency. Like in TDT, you don't have the issue because they're coming for the transfusion visit. In NTDT, our challenge is to get the patients to come to begin with. So any frequency to us is always good because in many cases we have patients that start coming to the center, they see they don't have complications and they stop coming anymore. But an assessment of with the fact that we're saying hemoglobin is usually steady in these patients. It's not going to just suddenly decline like you have in other diseases. Ferritin is more or less very slow to increase due to intestinal iron absorption. So for a patient that is, let's say, in their adolescence or early adulthood without any complications with favorable values in ferritin and hemoglobin, I don't see a reason why they would need to come more than twice or 3 times a year to the center just for a checkup. But we started because we know now that many complications start from the age of 10 or the age of 18. We're always recommending to follow the same frequency of assessment for the complications themselves. But you can always space them out if you see that they are normal for a while. So you need to start doing your DEXAs at the age of 10 or 12 because we know osteoporosis is high to at least have a baseline. But if it's stable for the first three follow-ups, then you can do it every 2 years instead of 1 year. So it's a little bit subjective. We do have recommendations in the TIF NTDT guidelines, but I would say we took the average of the patient that is not problematic now, but could be problematic based on treatment needs. Now, once you start intervention, your follow-up becomes different. Obviously, if they're on a regular transfusion, you need to follow them up more frequently for serum ferritin and with NLIC. If you started any of the new drugs, luspatercept, mitapivat, they have their own frequency of. But we're talking at an NTDT patient that doing fine on their own without complications now. They can be followed 2 to 3 times a year for their hemoglobin and iron, but to have screening for complications, especially when they start getting into adulthood, at a frequency similar to TDT in the beginning, but then you can space it out if they're working fine. One thing I forgot to mention when we speak about iron is that in almost all of our studies, even in patients with very high liver iron concentration, we always found clean hearts when it comes to iron. So, for some reason, because of the mechanism of iron loading, it doesn't look like heart iron overload happens in these patients. Probably it does happen later in their late adulthood. So, the focus of the cardiac examination even is more on the pulmonary hypertension and right-sided heart disease rather than iron-related cardiomyopathy.
Yeah. Thank you. So one practical doubt. So since you mentioned at least 6 monthly follow, or 4 to 6 monthly, I think. So these children are on hydroxyurea, right? So in our centers at least. So how frequently would you advise that CBC monitoring for hydroxyurea? Would you want to do it only when they come to the hospital, or would you want them to do that locally?
I mean, the steady state, once you achieve your steady state in terms of the hemoglobin response, I think you can space it to the visits. They don't need to come specifically for it. I mean, all of our concerns also for leukemic transformation, etc., and hydroxyurea, there is nothing solid now to justify that. And I think the standard frequency is enough to look into any changes that are going in the wrong direction.
So unless there is a fever or something else, you don't
Correct.
need
No,
to do
that's a
a
different story.
follow.
Obviously, we're talking about the steady state.
Yeah. Okay. Thank you. And Dr. Pranthar, and when you follow up adults with NTDT, what are the specifics? So this lady has pulmonary hypertension. What are the other specific complications that you look for NTDT patients?
Yeah, so obviously I look for extramedullary hematopoiesis. I take a good history and also look at the neurological system. I specifically make it a point to look for leg ulcers. And one important thing is endocrine and bone disease. No, because uh, some of it I've seen also is because I do not know whether because we are in a tertiary care center or not. We often now have them with liver fibrosis and chronic liver disease. So at least look at the liver, the kidney. We at least do urine routine testing. And as I told you about extramedullary hematopoiesis, thrombosis, we try to take a history. And for silent cerebral infarct, obviously we do not do MRI screens or anything, but we try to understand how the patient had been in the last 4 to 6 months. And for pregnancy related, obviously, it is similar to TDT. But otherwise, I think this extramedullary hematopoiesis, leg ulcers, liver and kidneys, along with bone disease is what we look for.
So this is something which has been, as in I have wondered about, like in thrombotic conditions, we for most of the other things we can actually predict, right? This is going to happen. Like the spleen is increasing, there's hypersplenism will set in, or low
Yeah.
hemoglobin, pulmonary hypertension should come in. For a thrombotic patient, do we wait for the thrombosis to happen, or can we do anything before that?
Yeah, so I do not routinely even use low dose aspirin unless if I see somehow, even with an intact spleen, the platelet count is high, I usually don't use routine prophylaxis. I think Khaled would be able to tell us what he does.
Yeah, so what we're doing now is we try to develop a mini risk assessment model. You know, those RAMs are famous in the thrombosis world. At least it was published in American Journal a few years ago, but it's not like validated or anything. What we're
Hmm.
usually saying is treat those patients, treat NTDT as an additional high risk criteria in the standard medical and surgical risk assessment model. So you still would apply the mobility factors, the travel, the surgery, the whatever. And, you know, if you're on the threshold, but this is an NTDT patient, especially if it's a splenectomized adult, then you will elevate that score and act accordingly. So we're still using the same risk assessment models we use in medical and surgical, but consider that the adult NTDT splenectomized is like an added point on those risk assessments, so we can act accordingly.
Okay, so in the taking that discussion bit forward, so in a pregnant lady who is NTDT, especially if she has been splenectomized, would you advise thromboprophylaxis during the peripartum period?
Usually in our practice, we do.
Okay,
Yeah,
nice to know.
because we have had a lot of incidents.
Okay, thank you. Dr. Pooja, coming back to you regarding this pulmonary hypertension. So when should we start evaluating and how would you evaluate for pulmonary hypertension? That's again something which comes up only on a testing, which generally there are not many symptoms, so the patient will tell us.
Yeah, so definitely the risk is higher in older patients. So if you have a patient in the 20s or 30s who's in follow-up with you, you should actively look for history of, like in this case, it was a subtle fatigue and weakness that the patient was complaining, and then the pulmonary artery hypertension was picked up. And more often than not, you will not have the overt features of a right ventricular heave, a loud P2 and TR being there. So you have to look for these subtle signs and look actively for Doppler, where you can look at the tricuspid, or the echo where you have to look at the tricuspid velocities to pick up. The other thing, a clinical setting, you can do a 6-minute walk test, which will indicate if the patient is unable to complete or has a walking distance which is less than 400 meters. And you should actively refer your patient for a cardiac assessment. And definitely, as Dr. Musallam also said, that more often than not, it's not the cardiac iron overload which is a problem, but the pulmonary artery hypertension, which is leading to the cardiac symptoms that the patient has.
So a lot of symptoms would overlap with anemia as well as the cardiac issues set pertaining to that. So not many things that we can follow up clinically, but it would be nice to have a NICO periodically for these patients, at least annually. So I think the first question regarding ferritin, I think you already discussed, Dr. Musallam. And so in the chelator, in the choice of our chelator, how does this understanding of differential iron overloading between TDT and NTDT, how does that translate into practice?
Yeah, so we have a lower starting dose, so there is a different label for NTDT in terms of the starting dose, the increment after 6 months, and the maximum dose. And these were all based on the Thalassa trial, and there was a follow-up Thetis trial that ran for up to 5 years. So in the TIF guidelines and in the label of deferasirox, we have a different dosing scheme for NTDT that's broadly on the lower side of the dosing for TDT because you don't have that heavy iron intake due to transfusions. With the ferriprone and DFO, the ferriprone only has one study in NTDT, but it's not specifically approved there. So to be honest, I personally don't have experience in practice. How is that working? Because the ferriprone label is only for TDT. It's not for NTDT, but I'm sure it's being used off label in some areas. So the first chelator choice will have to be the ferrosirox. That's where we have the data. And we've seen really, really good responses. You know, the LIC is cleared from 14, 15 to 6, 7 in 1 year on the trial. It was a very deep and good response because we know the ferrosirox specifically has good effect on the liver more than on the heart. And that's a problem in NTDT because we don't have much of the cardiac iron overload as a problem.
Okay. So for us again, so deferresirox continues to be our first choice
Yeah,
in
yeah,
these settings as well. So what about this patient? So this is a lady who had 700 ferritin and a moderate liver iron overload. So um, I think you would agree, Dr. Pooja, would you start?
Yeah,
And,
so I would put her, considering you have the MRI report, which is suggesting, and the patient is also having pulmonary arterial hypertension.
correct. Yeah,
Don't just look at the ferritin value. You will look at the patient clinically as well as the MRI value to decide on chelation. And regarding deferriprone, I'll just add that we do have at our center few patients, because in the early 2000s we did not have deferresirox.
deferresirox. Okay.
So we were using deferriprone in our patients, and I do
Mhm.
have a few patients who have done well on deferriprone, and
Oh,
they
okay.
don't to switch the on deferresirox.
No,
So
no, of
even if
course, if it's working, there's no reason to.
yeah, so we do have some experience. Although now we do use only deferresirox because of legal implications and because liver iron is a major problem. So I would choose deferresirox over deferriprone.
Yeah.
and I think without saying it, the patient needs to be on a transfusion regimen as well, right? You would
Yeah.
shift to a transfusion regimen considering the cardiac issues,
The pulmonary
Yes.
hypertension, yes.
pulmonary
And
hypertension.
so we've done a study in Italy to look, because when you look at pulmonary hypertension through echo on the TRV values, you hear alarming figures of pulmonary hypertension of 20 and 30%, and we knew that's not the case. So when we took the patients that had high TRV and we've done cardiac cath, the percentage, the incidence was around 4% in NTDT patients. It was still very high, obviously, compared to the normal population. But sadly, in those patients with pulmonary hypertension, followed up for 9 years, even though they were treated with some sildenafil, some different drugs, mortality was 40%. So pulmonary hypertension should be considered a critical complication that needs to be managed in every way possible and preferably through regular transfusion.
And this would be lifelong regular transfusion for her. That is what would be advised. Or
We had some patients that reverted back when they achieved a good hemoglobin level. Tried the period of decreasing, not removing completely the transfusion, so they receive it every 2 months or 3 months just to have something to help. And the pulmonary hypertension was reversed, and even though at a very small transfusion level, again, it's a patient by patient situation.
and if it reverses, would you stop transfusion?
I mean, that's why we were not, we were too scared to do that. So we kept the patient on a much lower
Lower
frequency of
threshold.
transfusion. Yes, it became every 3 months instead of every month, and the situation remained okay.
Yeah, okay. That's nice. What about leg ulcers, Dr. Prante? Very tough to treat. Just quick
Yeah,
points
yeah,
on how. Yeah.
yeah. So obviously, you look at the surrounding area. Sometimes we do a Doppler study to look at the flow also, but ultimately, what works is transfusion and hydroxyurea. So again, these are the two things which actually matter, because other than local things, and sometimes actually what happens is when they go to a general OP or something, people do not realize that it's a part of the problem, and then they come late to us. But frankly speaking, around 10% I have not been able to heal those ulcers completely, even with regular transfusion and hydroxyurea. So I do not know what to do with them then.
So, one small doubt regarding this. So, many a times
Yeah,
before the ulcer actually comes in, you would have some discoloration of the skin. There is a hyperpigmentation of the skin in the leg, right? So, would you put them
right,
on a
right.
transfusion regimen even then, or would you
See,
prophylactically?
yeah, in our cohort, since we are all brown skinned and all, sometimes to pick up that pigmentation also is difficult. We look at it and we have a lot of post-inflammatory pigmentation also.
Hmm.
So I do not start it then. I know that, the pathophysiology is something like that. But what I tell the patients is, please have a look. And, I sometimes counsel them as if they have diabetic foot, right? So you do it, wash it and watch it. But yes, some ulcers are very recalcitrant to whatever I try to do.
Thank you. And so I think for most of the complications that we discussed till now, Dr. Musallam, transfusion seems to be a good way to improve. And you showed also that it improves overall, but just the burden of transfusion that is going to be a big difficulty. So that was my question again. So a lot of
Yeah, yeah.
parents actually come back and come and ask us, even the other way around, that whether this child should be on a transfusion regimen
Mhm.
for growth despite NTDT issues. So what would be your answer?
Yeah, we cannot deny the value and benefit of transfusion in terms of just correcting the ineffective erythropoiesis, because also not only you're improving the anemia, you're shutting down the primary iron overload, the hypercoagulability, so you're saving everything. But again, we have the issue of the secondary iron overload and iron chelation. So it's a double-edged sword. It's again, we don't have currently very set recommendations on who to treat with transfusions because the list is long. And if we put all of these, then it means that everyone should almost be so, because it could prevent the complications and could treat complications. Our hope is that with the advent of the novel therapies, that we will be able to improve this hemoglobin without having to resort to transfusion therapy. But as we all know, access and affordability is being the main challenge now. Um, there are obviously the choices of hydroxyurea, etc., that could do the job in between. So it depends. I think in some patients, a combination of transfusion for a period of, like we said, in the growth period, and then they could be switched to hydroxyurea. And then if a pulmonary hypertension shows up or something that requires better hemoglobin management, you switch. So at the moment, it's very individualized, the treatment, but the role of transfusion is unquestionable in terms of decreasing the complications we see in NTDT. We even see these complications in suboptimally transfused TDT, so it's the same in both way.
True. So one more add-on question to that. Um, in which group of patients of NTDT would you consider bone marrow transplant? Like, should we be even counseling them? A lot of parents, when we tell them that you don't need a transplant, also they're worried about the morbidity of the disease. So
Mm.
that's something I think would have been considered in high-income countries also, like long-term, just keeping them on a little low hemoglobin with ineffective erythropoiesis versus curing them. So what is the current understanding on that?
To be honest, theoretically speaking, any NTDT patient could be eligible for if they have a matched brother. If you can cure the disease and avoid these complications, even if they will come in 10 years and so on. Now, the ones that most of the time, what happens is the one that were NTDT to start with. Then the physician or the patient trajectory put them in that very severe disease to the extent they became TDT. They're already among us as TDT, and we're actually considering them even in the trials. So in most of the trials, we have so many patients that are in the TDT trial, but the reality is they became TDT maybe in their late teens or even in adulthood. They were always NTDT. So these patients, we see that they actually are the best responders. So those phenoconverted NTDT to TDT, they responded better to luspatercept,
Yes, sir.
mitapivat, to everything. So
Mm.
maybe those are good transplant candidates in one way or another, but they're already TDT. Now, if we're talking about the NTDT, maybe patients that have complications that could be reversed. Significant impact of anemia, not able to get hydroxyurea for some reason or transfusion, the transplant could be considered. We're always debating this, should we start thinking of transplant? Now the conditioning regimens are better, experience in transplant is better everywhere. But I think the weight will always be on the safety of transplant rather than the need for NTDT. NTDT will always need some treatment. So if transplant is there, yes, like what could argue why wouldn't we consider transplant for these patients, especially the ones with a hemoglobin of 7 or 8, so they barely made it to be NTDT, then they could be the priority group. And then, I mean, if an NTDT patient is living with a hemoglobin of 11 without complications, their life is fine, then yes, you would question why would you put them. But let's say the average group of NTDTs are in that zone that require some intervention.
Yeah, and by the time they develop those complications, their transplant window will also be out.
Of
Their
course,
safe
especially also
transplant,
that
yeah.
they end up, in their 30s and 40s with major liver disease, with vascular issues. So yes, the risk becomes higher, obviously, or even not eligible at all.
Thank you. So it's something to watch out for. So
Yes.
last comments from Dr. Pranthir regarding counseling for pregnancy and thrombosis risk in NTDT.
Yeah, so what I usually do is I tell them that your thrombotic risk is more, and obviously in pregnancy it increases further. Now, what I see in practice nowadays, most of the pregnant females, as it is considered as a high risk pregnancy. Most of them would be on low dose aspirin, and I usually put them on low molecular weight heparin prophylaxis, considering that there are studies which show that there is increased risk of thrombosis. And as far as counseling is concerned, we tell them that even after the baby is delivered, for 6 to 8 weeks, we continue it, and then maybe we switch off the prophylaxis. But more importantly, rather than thrombosis, we tell them that every pregnancy in this case is a high risk pregnancy, and it should be managed by a comprehensive care team and not in isolation in certain district or block hospitals.
Okay. Thank you. So high risk pregnancy. So takeaways are that these are high risk pregnancies and they should be
Yeah,
monitored, seen by
yeah,
centers with have adequate exposure, experience, as
yes,
well as hematology service, at least
yeah, yeah,
consultation with the hematologist possible.
yeah.
So I
In
think with
fact,
that, we come to the end of the panel discussion. Yes, sir. Yeah,
right.
please
Yeah,
proceed.
I was just trying to tell you that there was one patient who suddenly required transfusion during pregnancy, and the ferritin value is now 825, and there she has already been prescribed deferocerox. So I said, see, we have managed this. Let first the baby be delivered. We will manage the iron overload later. So, what happens is, what I'm trying to tell the audience is that it is a multidisciplinary approach which should be taken, because pregnancy is a different ball game where you cannot use most of the drugs. So we deal with it accordingly, but both the treating obstetrician and the family should understand that.
Thank you. So with that, we come to the end of the panel, and there are, I think, a couple of questions in the chat. We can take it. First question is on any specific nutritional intervention for TDT versus NTDT. Pooja, ma'am?
Folic acid is something which you need: calcium, folic acid, and vitamin D. So these are the specific nutrients you must look at. So even when we talk of pregnancy, we should ensure that before the pregnancy, the patient is taking folic acid, and she must continue during pregnancy as well. And like for other hemolytic anemias, thalassemias, folic acid must continue. Regarding the bone health, we discussed, it is a problem in these patients. So regular calcium intake and monthly vitamin D supplements, or maybe low dose supplements on a regular basis, should be taken. A proper diet, and of course the measures like to decrease iron overload, your green tea, your tea with meals, those kind of things to
Yeah.
decrease iron overload should be done.
And it's very relevant because most of the NTDT's iron is coming from gut absorption, so it even becomes more
Yeah,
logical to use these approaches.
yeah.
Thank you. So next question from Dr. Bhandari. For patients on hydroxyurea trial, should we withhold transfusion for the trial period, or transfuse only when there is an ensuing cytopenia? I think when you initially start them on hydroxyurea, I think that's probably what he means. So it has been discussed that you would start if for NTDT, I think I'll just answer for the panelists that you would start on hydroxyurea and see how the hemoglobin response is, and then within 3 to 6 months you get to know if the hemoglobin is dropping less than 7 during this period. Of course, you would transfuse during this period. And there's one question again which I'm not able to understand. Is there any difference in the? I think it is BMR only between TDT and NTDT. I think it's maybe uh,
BMT
Is it
maybe,
about,
even.
BMT or BMR. I'm not really sure.
I don't know, because BMR means basal metabolic rate. So I don't know. I think are they talking of bone mineral density or BMT?
I think
We can
let's
answer
leave
all
the
three. So
question.
if it's for BMT, BMT, we don't have basal metabolic rate. Yeah, they
Right.
corrected
Yeah,
that.
yeah,
Okay.
yeah,
Yeah.
yeah, yeah.
I think maybe what he means is like a lot of NTDT patients, especially with a big spleen, they look very cachectic, right? So
Mhm.
Right.
they look more like, so they're with anemia on board. They may be having a higher BMR than is. I don't know if that's what was meant.
Yeah.
Dr.
Most
Musallam,
likely.
Dr. Prancer.
But no,
Uh,
nothing specific. There
nothing.
are a
Yeah.
few metabolic studies in the field, but they're more geared towards energy levels and energy consumption due to ineffective erythropoiesis, etc. But at the level of the typical sense of metabolic rate, I'm not aware of any data. I mean, the the only thing I can say is the body of an NTDT patient, because they're not getting any support, is struggling more than the TDT patients. To be able, the ineffective erythropoiesis itself takes a toll on the body compared to a well transfused TDT patients. So the chronic anemia itself and hypoxia must have an effect on that.
Okay. Thank you. I think with that, we come to the end of this discussion. There's a question on gene therapy for thalassemia in future. I think it's not future,
So
it's present. Yeah.
currently we have the gene addition Betty cell that is approved for thalassemia, and we have the gene editing with CRISPR-Cas9 targeting BCL11, the Casgevy or exa-cell. There are no active programs that are still ongoing. There was Reni-cell, which provided just good data recently, but the program is not moving forward. And there's a ton of gene therapy programs coming from China lately, more or less similar to these programs, especially the Betty cell, but with different approaches and platform. There's a lot in animal studies and preclinical in vivo gene therapy, combination of beta globin and gene editing. So the field is in its prime now in terms of development. So we do expect to see more clinical programs soon, but hopefully we'll see better access options also. So this is an option for all patients everywhere, not only for a few privileged.
Thank you. And there are, for those of you who have joined from India, again, so there are trials which are being done in India as well. So with that, we come to the end of today's session. And okay, there's one more question. I think we could take it
Thank
because
you.
we did not
Yeah.
discuss
I don't want us
thalidomide
to leave.
today deliberately because we had repurposed drugs in the last month's session.
Yeah.
So role of thalidomide in TDT versus NTDT, any data available?
I've recently wrote on this, so there are two nice systematic literature reviews published in the last year or so. One for NTDT and TDT, looking at monotherapy. If you look at the conclusion of all, it does work, but in the same context of hydroxyurea, specific patient populations, etc. But thalidomide, I think we're a little bit more concerned with safety than hydroxyurea, especially for long-term use. So again, without the clear large clinical trial data, although I know there are few that came from India, it has to be a physician choice, careful patient selection, and careful monitoring for safety, especially on the long term. But we see the effect. Thalidomide started much later than hydroxyurea, becoming more of a let's say, in the literature in terms of attention, but we've even had cases that needed thalidomide for something else, and suddenly we saw that transfusion requirement decreased. So something is happening there, but I would put it in the same basket of hydroxyurea, but less evidence, more recent evidence, and a little bit of a higher safety signal.
Thank you. So that's again one space to watch out for, with more trials coming in and
Correct.
emerging evidence. That's something
Correct.
which can be, especially in resource poor settings where luspatercept and mitapivat can be concerned. So I think we'll close the session for today. I'm really, really thankful to all the experts who joined us today. Dr. Khalid Musallam for sharing his wealth of information with us. Dr. Prantha Chakrabarti for, as usual, practical, very clear, lucid replies. And sir is joined from the airport today, I can see. So thank you very much, despite your difficult schedule. And Dr. Pooja ma'am for again very clear answers to that, so the practical answers to our questions. So thank you to all of you. And Dr. I think Shobha ma'am has not yet joined, so I will just close with the key messages. That definitely NTDT is a space which is not should not be undertreated or
Correct.
underdiagnosed anymore. This is something which requires probably as much or even a little more investment from a healthcare sector towards our patients. And so that can be done with longitudinal follow-ups and registries in place, which we can work on our patients more. And it's something which we need to be very actively invested in terms of new drugs, the new drug development also. So I hope there are new drugs which come up which can benefit this cohort much more than our TDT patients. TDT patients currently have an option of curative treatment, which is not offered to NTDT at present. So that makes it all the more important for these patients.
Correct.
I would like to thank Thalassemia International Federation for handholding us through these sessions, Thalassemics India for their support, and to Eco India for being the logistic partner for holding these meetings. So thank you all for a great session today. And this session the recording will be available on a dedicated YouTube channel by Eco India. We'll share the link with all of you in case you want to revisit it at some point. Thanks again to all of you.
Good afternoon.
Thank you, everyone. Thank you. Bye-bye.